Good afternoon. My name is Debbie Goff. I'm an infectious diseases clinical pharmacist at The Ohio State University Wexner Medical Center in Columbus, Ohio. I am a founding member of our antibiotic stewardship program, started back in 2000. I see antibiotics save patients' lives, and I also see antibiotics create harm. So when you get C. diff and it's life-threatening, I'm the one taking care of you. I am a TEDx speaker in 2016. If you YouTube TEDx and my name, you will find my talk, Antibiotics Just in Case, because that's why they're prescribed a lot. Not really indicated, but let's just give it to them. And I start my talk with a patient, 32-year-old woman, mother of two, who received an unnecessary antibiotic, developed C. diff, got admitted to Ohio State with toxic megacolon, and died. And I can remember her like it was yesterday. And I'm very passionate about educating healthcare providers on the appropriate use of antibiotics. We do need to use antibiotics. They do save lives, but as you all know, they're passed out like candy bars throughout the world. I also work globally. I have a program down in South Africa, and I've worked in all countries around the world, and I work with the World Health Organization trying to implement antibiotic stewardship programs around the world in countries that do not have the healthcare infrastructure like we have in the United States. So you're working with people that, just don't have our level of knowledge in infectious diseases, but we need the whole world to be engaged in appropriate use of antibiotics because we've run out of effective antibiotics. So it's not just a problem here in the United States and we can live in our little bubble and go, it doesn't matter what's happening in Africa, because we know everything infectious diseases is a plane ride away. And so I do treat patients with untreatable infectious diseases because we have no effective antibiotics anymore. And it's devastating. So I watch patients that survive their cancer only to acquire an antibiotic-resistant infection while their immune system's recovering, and they ultimately die from their antibiotic-resistant untreatable infection. And that makes you pause. And that is why I'm so passionate about antibiotic stewardship and work really hard to do this. So today, my focus is on dental antibiotic stewardship, as I've heard many of your C. diff cases were a result of a dentist prescribing an antibiotic. So let's just get started and I'll explain a little more how I got into dental antibiotic stewardship. So dentists prescribe about 25 million antibiotic prescriptions a year in the United States, but they are the #1 prescriber of clindamycin. Why is that? Because that's what they taught in dental school for decades. In fact, many dental schools are still teaching it. If you are pen allergic, the drug of choice is clindamycin. So, as you know, a single dose of clindamycin given orally or IV can cause C. diff, and it is the antibiotic that has the highest risk of C. diff. Any antibiotic can cause C. diff, but it is very prevalent with clindamycin. So, look at this nice study. This is a very prestigious journal, JAMA. So Katie Suda is an infectious disease pharmacist. She assessed the appropriateness of dentists prescribing antibiotic prescriptions for prophylaxis. So that's before you have the dental procedure. And how well did they do? 81% of it was unnecessary. Now think about that. It's pretty overwhelming. But I'm going to explain why. So if you have a joint replacement, hip or knee, the orthopedic surgeons to this day, most of them will tell their patients, you need dental antibiotic prophylaxis for life. Make sure you tell your dentist that every time you go. And that represents maybe 3.8 million unnecessary dental antibiotic prescriptions. So there is this very unique dynamic between orthopedic surgeons and dentists, and it creates confusion because they're both struggling with how to recommend. So if you have a hip or knee and you get a dental procedure, there is a less than 1% chance that there's a relationship between the procedure. When you mess around with the gum tissue, you can cause what's called a transient bacteremia, meaning you can inject bacteria from your mouth into your bloodstream, and that bacteria likes to find foreign bodies, meaning your hip replacement, and it hooks onto it, and you can get a hip infection or a knee infection. And the principles of infectious diseases, how do you treat? You remove the source. Well, you can't just take out the hip replacement and go put in a new one. So you have to understand, why are orthopedic surgeons fearful of patients getting infections? Because there's not a simple fix. Okay. So that's where the mindset of give them antibiotics to prevent any potential infection, even if it's less than 1%, that's where it comes from. So now you're the dentist and your patient's walking in the door, oh, I was told I have to make sure I don't get my hip or knee infected. I need an antibiotic. And that's where that confusion starts coming in. So let's just switch to physicians, because in the big scheme of things, physicians prescribe 47 million unnecessary prescriptions every year. So they're really the bulk of the overuse of antibiotics in the United States. But every healthcare professional can do better. And we're working really hard to make that happen. But you're trying to change the mindset of decades of what we were taught about antibiotics. They prevent infections and they're pretty benign. That's the mindset of most physicians and dentists. All right. So there's a lot of opportunities for improvement, and that's where I work. So when others have looked at evaluating dental antibiotic prescribing, they notice that the durations of therapy are generally pretty prolonged, 7, 10, and 14 days. I call them football scores, because that's what they are. When you go back and look at where did these durations come from, it's just how the practice, the first recommendations use those durations, and that just continued on. So there's not a lot of evidence to support these durations. And now we have learned every day of an unnecessary antibiotic can create harm. And one of those harms is C. diff. So now there's more science to say that idea of just giving people antibiotics for long durations because no one wants to get an infection. When you've invested $50,000 in your implants, you don't want them to fail. So of course, the dentist is going to give you 14 days of antibiotics because they don't want those implants failing either. And that's the mindset you have to think, where is it coming from? So how did I get involved in dental antibiotic stewardship? I work in a 1,400 bed hospital, and it's all I can to do antibiotic stewardship there. And then I work globally also. But my husband is a private practice dentist. He's a prosthodontist. And he came home one day and he's like, well, I was being a good steward of antibiotics. And I had this patient who had her hip replaced 20 years ago. Surgeon told her, make sure you get an antibiotic prophylactically before every dental procedure. And she's like, oh, I forgot to take it. I need you to give me my amoxicillin. And he's like, oh, nope, the guidance has changed. It's no longer recommended by the American Dental Association. And my wife does this as an expert. There's harm from antibiotics. And, he gives her the whole explanation. That takes time. And the patient was elderly, and she just sat there confused, stuck in the middle. Do I follow my orthopedic surgeon? Do I follow this dentist? And was like, I don't know what to do. I'm leaving, and walked out. And I said, that is ridiculous. The patient should not have to decide which doctor do I listen to. That's not your job. This is insanity, and we're going to fix it. So I wrote a grant and I received funding to bring the two groups together. So some of the challenges with dental stewardship, most of all the publications in the medical and dental literature are done in the VA system, which is a very controlled environment. They create evidence-based guidelines, and those policies become the standard of practice, and you don't really have a choice to practice outside of those guidelines when you work for the VA. But what percent of dentists in the United States are in private practice and not in that VA system? It's 74%. It's the bulk of them. So when I asked the CDC, Dr. Hicks is the physician in charge of dental stewardship, why is all your work in the VA system when most of the dentists are in private practice? Her answer was, we have no access to them. They're all on their own computer systems, and there's no way to do this study. And I said, well, I have access to them. My husband's one of them. So I went home and started thinking about it and wrote a grant and was awarded an opportunity. And my goal was, I'm going to bring the orthopedic surgeons and the dentists together, and I'm bringing the CDC to watch this. And can we make an influence? My neighbor's the orthopedic surgeon in private practice, and my husband's in private practice. So I said, okay, you two, don't embarrass me. You get your friends to come to this dinner program, and we're going to have a town hall meeting. The draw is not Ohio State University faculty. They could care less about us, and the last thing those orthopedic surgeons want is someone from Ohio State telling them how to do anything. The draw was, tell them the CDC is coming, because I can assure you, just like in the hospital, antibiotic stewardship is coming to your office sometime soon. So you can have a voice at the table now, or wait till we create the policies that dental stewardship will be required in all of your practices. And that's how we got them to come. So there's a strategy to engage people, and that's what we use. So what did we do? Myself, the physician I work with, we gave a little 10-minute talk on there's antibiotic resistance. We are out of antibiotics in our hospital for some patients, and patients die. The CDC spoke about how they do, healthcare for the United States. And then we created 2 patient cases, and we broke our dentist and orthopedic surgeons into little groups, and they had an hour to work on these cases. Our goal was, could they come to consensus? When you meet your enemy and now you're face to face, there's a little different interaction than when you're just sending emails or on social media. Now you're sitting there with the orthopedic surgeon who's telling all of your dental patients they need lifelong antibiotics. And you're like, I've never met you. Well, I've never met you. And, guess what? They're both reasonable people. And pretty soon you just watch the barriers break down. And I wish we could have videotaped it, because the orthopedic surgeon, who I knew was one of the advocates of lifelong dental prophylaxis, stood up and said, well, on the first patient case you gave us, I learned something new, and I will no longer be recommending this. We came to consensus. There is no evidence to support this lifelong prophylaxis that I've been recommending to all my joint implant patients. And it was really amazing. But again, it was a small group of 26 people. And I just sat there and thought, if we could succeed at this little grassroots effort, could we scale this up? And that's what the CDC was interested in. This was amazing, Debbie. We've gone to the ADA, the American Dental Association, and met with them, policymakers. And there's one person from the ADA that's here today. I don't see her, but she's speaking later. And we've met with the American Academy of Orthopedic Surgeons independently, but we've never had them in the same room together. And the dynamics when you bring them together, if the orthopedic surgeon guidelines say, we believe you should give dental prophylaxis, but the ADA is saying we can't really find the evidence. How does that help the patient when you get 2 organizations telling you opposite things? is it what you're supposed to make the decision? So, that's really hard. But when you bring the two experts together, you can actually go, look, we've got to get on the same page. The patient shouldn't be the one trying to decide what to do. We're supposed to be the medical experts. So let's put our expertise together and come up with one recommendation. And that was my goal. And I've learned you've got to be your own best advocate. So in order to engage others, I work for Ohio State. We have a public relations whole group of people. I called them. I said, hey, can you get us the newspapers, our local newspaper, to write up this story? It's really important. And yes, we did. So this was, look at that cute little picture they put in there of teeth. Shifting thoughts on if joint replacement patients need antibiotic dental work. So, you're planting the seed. So hopefully consumers were reading that. The orthopedic surgeon might be reading it. Anyway, that's part of what we do. The other thing we did is we brought in our hospital lawyers. As my husband said, if you don't have lawyers present, don't bother doing this, because I want to have you understand the fear of lawsuits when you're in private practice and how that drives a lot of behavior. So the first thing we asked our group, have you heard of dental antibiotic stewardship? And the answer was no. There wasn't a single physician that even knew what it was. So this is a really important thing. We're all aware of it. I do it for a living. But when you're talking to groups, do not ever assume they know what antibiotic stewardship is. So again, these are orthopedic surgeons and private practice dentists. Never heard of the term. So we published our work. When you publish, you can teach the world. And part of what we looked at is we asked the dentists and orthopedic surgeons, do you prescribe prophylaxis as defensive medicine, meaning fear of lawsuit? Patients love to sue doctors. And I'll show you the results. And then we asked them, are you ever informed of when your patient develops C. diff? And the answer is no. And that's why I had the CDC there. They create public policy. And you did a wonderful job explaining that. So when you're trying to change the behavior of dentists, orthopedic surgeons recommending antibiotics, if they have never seen harm from their prescribing habits, they will never change those prescribing habits. And there lies the problem in our healthcare process. They never see the harm. When you get C. diff, are you running to your dentist? Are you running to your orthopedic surgeon? You're running to us at Ohio State. You're in my emergency room and I take care of you. And once we take care of you, guess what? We have no reporting mechanism to go, so who wrote your prescription? Your family practice doc, your surgeon, your dentist. And honestly, that's not my job to go sit and then call. I mean, I have all I can to do what I do in the hospital. There's no mechanism for this. The mechanism is you, the patient. But what if you, the patient, doesn't recognize that unnecessary antibiotic from your dentist or orthopedic surgeon caused your C. diff that developed 4 to 5 weeks later because you've never even heard of C. diff? So you can see how all these missing pieces is why the dentist and orthopedic surgeons have no clue their antibiotic prescriptions are causing harm in anybody. Because when you read C. diff or you read about side effects of antibiotics, you think, oh, yeah, it happens, but not in my patients because no one's ever told me about it. And there lies the problem. So you have a lot of power in relaying the information back to your healthcare provider. So in our analysis, I am notified whether a patient develops C. diff. 5% of dentists knew and 12% of orthopedic surgeons. But keep in mind, we only had 8 orthopedic surgeons at our meeting. It's not like there were 800. But defensive medicine prescribing, fear of that lawsuit when you're in private practice. So I don't want to minimize a lawsuit for any physician. But at Ohio State, things happen and patients or their family sue the doctors when something goes wrong. And it's not always our fault. You know, people die because they have bad diseases, not because we did something wrong to them, but a lawsuit. So when you work under Ohio State University, you know, you're covered. And during the lawsuit, you know, we have OSU lawyers and you're making the same salary. There's no change in that. And, you know, if you have to go to court, you're given time off. You're financially not really impacted. It's devastating. So I don't want to underscore the impact of that. But when you're a doctor in private practice and you get a lawsuit, guess what? You have to go to court. You are paying your entire practice overhead while you're at court and your business is bringing in no money. It's financially devastating, and your business is based on your reputation. And, you know, when something goes wrong, patients are very quick to put it out on social media and ruin your reputation that you can't ever get back. So I just want you to understand the little difference in a lawsuit and private practice, because that is what drives their decision making. The fear of a patient getting infected and I might get sued. Therefore, I'm just going to give them a bunch of antibiotics so nothing wrong can happen. And part of my education to dentists has really been helping them learn you need to switch that mindset, because if your patient gets harmed from an antibiotic that you really can't find evidence to support, if you're giving a 14-day course of antibiotics after you put a dental implant in, and I've read the entire literature, there's just no data to say you need that long duration. But I can find data that every day you give an antibiotic unnecessarily increases your risk of C. diff. You're going to get sued for the C. diff, not for giving the antibiotic. It's a different mindset. So start thinking about, could I get sued for the risk of C. diff and causing harm versus just not giving an antibiotic? And it's a different mindset, and it's working. So we did this study. We just finished it. I presented it at our infectious disease meeting last 2 weeks ago, our national one, with private practice dentists. So we got 20 private practice dentists to participate. And I know from my years of work in the hospital, simply asking doctors to do a better job at prescribing antibiotics has not and does not work. You can create guidelines galore. I've done 1,000 of them. And at the point of prescribing, they never remember what the guideline says and they keep doing what they've been doing. And it's all back end enforcement. So they've already prescribed the wrong drug. And now you call them up a month later and go, oh, I see in our data, you didn't comply with the guideline. But the harm's been done already. You know, how does that help? So enforcing guidelines is a full-time job. So when you publish guidelines, yes, we need them, but don't think it's going to change prescribing, especially in private practice. They may not even read the guideline because they have no one kind of overseeing what they're doing. You know, that's what I'm doing at Ohio State, but that doesn't exist in private practice offices. There's no one overseeing them or they're not being held accountable to these guidelines. Okay, so dental antibiotic stewardship. They have to know and trust me. So when I speak to all these dentists that I've been talking to, I just put that right out there. Look, I'm not a dentist. I recognize that. And you don't know me, but you do know my husband and all the other dentists that participated in our study. So they have invited me on their behalf because they trust me. So I'm going to make some game-changing recommendations in your practice. And if you don't believe me, then talk to your peers. The most important thing is why. If they don't understand why you're asking them to not use clindamycin, they're going to just keep on using it. So there have been dental guidelines in 2016 that removed clindamycin for penallergic patients. So why are dentists still the highest prescribers of clindamycin? Because they just don't read the guidelines. I already learned it. Why am I going to go read a guideline that I already know? And there is the problem. So we had to address risk of lawsuits, and that was really just flipping their mindset from, I am afraid a patient might sue me if their implant gets infected, so I'm going to just give 14 days of antibiotics, to me teaching them going, nope, there's no evidence for the 14 days. There is evidence for antibiotics. How many days? I can't answer that. Those studies just aren't done. But I know in medicine, for hospitalized patients with community-acquired pneumonia that we used to give 10 and 14 days to, we have 7 randomized controlled studies that tell us now we can treat you for 5 days. Why were those studies done? Because we know every day of an unnecessary antibiotic creates antibiotic resistance and harm. So I share with the dentist, I can't give you dental studies, but I can give you medical studies, and we're down to 5 days for a hospitalized patient with community-acquired pneumonia. So let me ask you, Dr. Dentist, you're doing an outpatient dental procedure. Why do you need 14 days? I don't think you do. I cannot guarantee it, and I can't give you a dental study, but I think what you're doing is harmful. And that creates behavior change. So we did this study. We collected all their antibiotic prescribing for 3 months in June of 2019, June, July, and August. We educated them. We had to do it on Zoom because of COVID in the evenings. Myself and Dr. Mangino, who's the ID physician I work with. And really, it was just like a dialogue. You know, we shared this data, and then they could ask us questions. And they're like, I've never had an infectious disease expert ever teach me. This is like mind-boggling. I had no idea I was creating harm. And then we immediately went into what's called audit and feedback. Their dental prescribing, I could watch in our live online database. We hired people to collect the dental antibiotic prescribing. So if their practice was still giving prescriptions for 10 or 14 days, every Friday I'd call them and I go, hey, tell me why you're doing that. And they're like, oh my gosh. And we literally shut this down. So the clindamycin was eliminated after our lectures. It is mind-boggling. And now we're scaling this up across the US. So one of the questions we asked them as we collected this antibiotic data, we would ask them, what is your typical antibiotic prescription written for? 5, 7, 10, or 14 days? And in our online database, before we educated the dentist, here's what we saw. This doctor gave 5 days. This one gave 7. This is real data. And this one. Okay, they're doing the same procedures. So my next question was, why? Why are you 10, you're 7, and you're 5? What do you think the answer was? It's what I learned in dental school. Okay, so there's a lot of work ahead of us. So we finish with, here's why we, in infectious diseases, in a hospital setting, who watch people that are harmed by antibiotics and also watch antibiotic save lives. Here's 3 reasons in the hospitalized critically ill patients, we are using shorter durations of antibiotics. So I suspect dentists can use shorter antibiotic durations for the majority of their procedures, but there are no dental studies. But here's what we share with them. And this is what I've distributed to many, many dental offices. Shorter equals less antibiotic resistance. That's a tough sell, even in the hospital, because you don't see that harm immediately. If I give you an antibiotic, I know, because I track historic data at Ohio State, you know, I can look at our antibiotic resistance rates from the last 20 years. But when you're prescribing antibiotics in the moment, you know, you can't usually prove your prescribing caused this resistance today. So it's more of a futuristic adverse event that occurs from antibiotics, and it's hard for physicians to grasp that. But the C. diff rates, a 9% risk of C. diff for each day of unnecessary antibiotics, that's a real fact. And then just the risk of any antibiotic-related side effect And so this is what we share with them, and we share that and teach the entire office. So did we make a difference? Here is what our data showed. So we advocated the average durations should be 5 days for the majority of procedures. There are some specific things they do that may require longer durations, but you saw those spreadsheets, they prescribe the same durations for everything. So we were able to flip this duration. I mean, look at this. It's amazing in just our educations with the dentists that were in it. But look at the volume of clindamycin. It was amazing because we told them firsthand stories of our patients that we see with C. diff and patients who we have witnessed dying from C. diff. So ways for you to get involved. Inform your dentist if you develop C. diff from the antibiotic that they prescribed. Inform your dentist, any healthcare provider, ever that tries to prescribe you an antibiotic. Make sure you tell them that you are a C. diff survivor. And do I absolutely need this antibiotic or not? Ask your dentist if they practice dental antibiotic stewardship. They may not know what you're talking about, so you can be the educator. I recorded a YouTube video. There's the link with a very prominent dentist in the Philadelphia area who 40 years of practicing as a dentist, teaches in the College of Dentistry, was so impacted by what I taught. He literally has changed his practice and is making it his mission to teach as many others. This is the power of what we can do. So dentists have learned to stop prescribing opioids. In the state of Ohio, you have to watch a 1 hour, you have to take a 1 hour continuing education program every year. Because they learned the risk is greater than the benefit. You can actually cause addiction in 5 days of an opioid prescription. You know, we really didn't know that before the opioid crisis. And so we have been able to change dentist prescribing of opioids literally quite quickly. So we can teach them to stop over prescribing antibiotics, and I'm watching it myself. So I'm going to conclude with one of the testimonies from a dentist who did not participate in my study, but the dentists who did participate have these national networks of other private practice dentists, and they educate each other. And they have plugged me in to speak at multiple dental study clubs, they're called, and they conduct them in the evening. And so I've given this lecture about responsible antibiotic prescribing. And Justin Zielinski is a private practice periodontist in the Washington, D.C. area. That's why I selected him since we're here. And he has a large 3 practice sites around the area. And I asked him to just give a quick testimony of the impact of what he learned for dental stewardship. So if we can go to that video.
Hello, my name is Dr. Justin Zaleski, and I am a practicing periodontist in the DC area. I met Debbie Goff about a year ago, and it was one of the most eye-opening lectures that I have probably been part of in the last, 10, 15 years. Since I first heard her lecture, I've actually heard her lecture 2 more times because I've actually brought her in to speak to different groups that I'm part of multiple times. Every time I get something new, and like I said, it was very eye-opening for me, and it completely changed the way that we are utilizing antibiotics in our practice. We used to, just blanket prescribe 7 to 10 days of amoxicillin. We're no longer doing that. We're down to 3 to 5 day doses of antibiotics. Clindamycin is no longer a part of the practice, which it should not be a part of anyone's practice. But even more importantly, it's changed my questioning of patients to ask more about C. diff, which is a major problem. And, unbeknownst to me, just in the last 6 months, I've identified 3 C. diff patients that had C. diff in the past, that if I had not gone through this lecture and met Debbie, I would have just treated them as normal and put both them and myself at risk. So I hope you guys enjoy your time with her. She has a lot of great information, and I hope it's as life-changing for you as it was for me. So thank you.
And I thank him. So can you make a difference as one person? Absolutely, yes. I will continue to fight for all of you to educate as many dentists as I can through this advocacy. And I really appreciate all of your stories, because that's why I do what I do. Thank you. Yeah.
First of all, you're a powerhouse,
Oh.
and I almost died because of clindamycin being prescribed to me, as I told you, for a preventative treatment for a root canal, and then my daughter, who was 22 months, almost passed away from a C. diff infection as well, and so it was just a nightmare. So thank you so much for what you're doing. I do have a question. I think a common misconception is that, and I have felt this kind of pressure before from doctors, but if you don't take a preventative antibiotic, when you get an infection, you'll need even stronger antibiotics. Is that accurate?
It actually, I would generally say yes. So there are many procedures. So a root canal, I don't want to generalize, but if it's concurrent with an abscess, antibiotic prophylaxis may be necessary. And the same with implants. There's a study, it was actually done at Ohio State, where they looked at doing a dental implant with and without prophylaxis and the risk of developing an infection post-procedure. The risk was 3 times greater if you did not give a dental antibiotic prophylactically prior to an implant. So there is evidence for that procedure. Root canals, there is evidence, but it's the post-procedure where there's just conflicting data. And so there's a lot of work that needs to be done. And that is challenging for me because I can't definitively tell dentists not to give antibiotics. So what I'm watching, Dr. Zielinski is a great advocate, because you heard him say he was giving 10-day durations. He was like, shoot, now that I've learned I might be creating harm, I'm going to go down to 3 to 5 days. And I keep this network of dentists close to me to share. Tell me if you have patients fail in developing infections, because maybe we're wrong. Maybe some of these things do need longer durations. I don't think so. But to date, that's why I had him speak. He's like, I've seen no difference. My infection rate is less than 1%. And there's multiple reasons why patients can get infected after. If they're smokers, your tissue won't heal and you're at a higher risk. If you're a diabetic, so it's not always failure of an antibiotic or lack of giving the antibiotic. So there's a lot of factors. You have to be careful you don't make too many claims when you shorten antibiotic courses and that. But there is evidence that prophylaxis for a lot of procedures is absolutely required. And for some, there isn't any evidence. So good question. Yes. Yes, please.
Oh, sorry. Thank you so much for your presentation. I just wanted to add, Christina, that I, having had dental implants, I did not have antibiotics. I discussed this with my dentist extensively. They knew my history, and I didn't take any prophylactic antibiotics, and I only had a mouthwash that I used. I also just recently had a couple of screws and plates put into my foot for a broken foot, and the orthopedic surgeon wanted to give me antibiotics. And I said, no, I can't have antibiotics. And he said, yes, you must have antibiotics. And I said, no, I will not have antibiotics. And we came to an agreement that I said, you have to understand. He did not understand C. diff, so I had to explain it to him. And I said, you have to understand the risk benefit for me is not there for the antibiotics. I'm not going to, go put my foot into a sewer. It's just, I'm going to take care of everything and it'll just be fine. And if it's not, then I'll deal with it then. But I know what's going to happen if I take an antibiotic, and it's not going to turn out well. And I did not have an antibiotic, and I did not have a problem. So you can negotiate with your doctors. I noticed when you tell them about C. diff, you can tell by the look on their face if they know what C. diff is, they look at you and go, "Oh my God, I can't believe you're alive." If they have no look at all of like you just had a wart removed, like find another doctor. That's all I can say.
That is really valuable feedback. And what that's called is shared decision making. So that's another key point I teach the dentist. The patients need to have a voice. It's their body. And so include them in the decision making. So when a dentist has an orthopedic surgeon insisting on dental antibiotic prophylaxis, and the patient is sitting there in the dental office, the dentist, we created in that paper I published literally a little picture that they can use. So there are risks involved in taking antibiotics, and because the evidence is not there to support clearly all of this antibiotic prescribing, let me explain the risk of taking an antibiotic and not taking the antibiotic. And then you, the patient, tell me what you would like to do. So if you can explain that, and that's what I'm teaching the dental offices, because the office managers and treatment coordinators are the ones actually interacting with the patient. So when they get to the dentist for the actual procedure, this has already been taken care of. So if you come in with a penicillin allergy, I've taught them what other antibiotics they can use. If the patient comes from the orthopedic surgeon insisting on prophylaxis, their job is to explain this shared decision-making tool to the patient. And then what I teach them is the one who writes the prescription is the one who gets sued. So let the orthopedic surgeon write the prescription. If they're the one requiring the antibiotic, I tell the dentist, don't dare write the prescription because you're the one who will get sued. And saying, the story, and I know the lawyers could speak to this, it's not going to matter. It's the one who wrote the script that gets sued. So don't write it. Let them. Yes.
Wonderful work. I'm so glad this is being done. So I have a question with the combination of the orthopedic surgeon and the dentist and the patient. It seems like it's still pretty common for orthopedics for the prosthetic joints. That's the main concern, is that continually you get a cleaning, you get a root canal, whatnot, is to do a course. And what do you think needs to be done in terms of that group of doctors with orthopedic surgery? Because that seems to not, I don't know if it's more prospective studies. I don't know if it's more involvement with their organizations. I'm not sure.
So the American Academy of Orthopedic Surgeons and the ADA came to a consensus in 2017, and their own guideline shows only 12% of patients maybe can benefit from antibiotic dental prophylaxis. They don't read their own guidelines. And in defense of the orthopedic surgeons, they look at, what if my patient develops an infection? It's really hard because you can't just go put in a second hip or knee. It's not like a tooth where, okay, I can extract that infected implant, we'll let it heal, and then I can put another one in. So the morbidity to the patient, if your hip fails, you could become wheelchair bound. So there is really a catastrophic impact to the patient if that hip or knee gets infected. But what we absolutely know is if you believe you should get dental antibiotic prophylaxis before a procedure, then you should be taking an antibiotic prophylactically every time you brush your teeth, floss your teeth, and chew food. Okay, well, that would be antibiotics 24/7, and you don't do that because that's really where the science is. You get transient bacteremia every time you kind of muck around with your gums. So that's why the evidence just doesn't support this. So it really requires orthopedic surgeons learning about stewardship. And I am proud to say that one of the orthopedic surgeons, one of the largest private practice groups in Columbus, Ohio, I recorded it to play it for every dentist I talked to. That orthopedic surgical group is no longer recommending dental antibiotic prophylaxis, and I applaud them. So that is one of the first groups in our town because all the others are still recommending it. So I actually have a call in to ask them what led to that change, because I know it's not the guidelines. My suspicion is that they were sued for C. diff, and that's what led to the change. I don't know that. I'm working because I want to reference them. That is, and they're a big orthopedic practice. So it's starting to occur. When you look at orthopedic literature and Google antibiotic stewardship, 5 years ago, 0 came up, and now it's coming up. And I think the reason why, because, you know, they do their surgery in hospitals, and when you start running out of effective antibiotics, it impacts surgeons in a big way. So I think they're starting to see that impact. Their patients that do get infected for various reasons are getting infected with antibiotic resistant infections that are really difficult to treat. So I think they're finally starting to see the consequence in rethinking it. So I am really encouraged. Anything else? Yeah.
Hi, Dr. Goff. We have a question online from Amanda Bonagora, and that is, do you have any knowledge about why dermatologists prescribe clindamycin? Her nephew had acne and took it, and her own son went to a different pediatric dermatologist, and she prescribed it too. As a C. diff survivor, she refused to allow him to take it, but she was amazed at the inability of a really smart doctor to think outside the clindamycin box.
Yeah, so in dermatology, that's been a long-standing antibiotic for acne, prescribed routinely. And until someone educates them on the risk, it's not going to change. So that you will always encounter healthcare professionals that think, I know more than you, and their egos won't allow a patient trying to tell them anything, whether you're right or not. My only hope is don't ever stop trying. Now, it is quite annoying when you have what we call patient doctor Google come in to tell you. And, you know, the internet's been a wonderful thing, but it also does create complexity because there's a lot of fake information on the internet. So when patients come in, you know, requiring these therapies that we know are not vetted in science, you know, it creates issues. But don't ever stop as a C. diff survivor or someone knowledgeable about C. diff, trying to educate that doctor, because here's what will happen. Because I work with them in our hospital setting when we started stewardship, and they were like, no, you're not going to tell me I can't use whatever I want to use. I'm like, well, we actually are, because I had all the data. So what happens is I call it planting the seed. They will walk away very combative, and you're not going to tell me anything. I've been doing this for 20 years. I know what I'm doing, and I always give clindamycin, and it works. But you're going to create a seed. They're going to go back and go, what was that patient talking about? Let me just Google this real quick. And they're going to go, I didn't know this. They'll never admit it to your face, but you will create that little doubt that will make them go, maybe, or they'll ask one of their colleagues they work with, do you use clindamycin? Like, to get validation that what I'm doing is best of care. Because I do believe every physician wants to provide best of care and not harm patients. But until you learn what I'm doing is harming patients, you won't change what you're doing. Thanks.